Okay, as people are trickling in still into the session, I will start by giving some just key pointers and information for this session. So first of all, thanks everyone for joining. My name is Gabriel Altit. I'm a neonatologist based in Montreal, and I co-chair with Dr. Amy Stanford the Targeted Neonatal Echo Foundation Curriculum for the Neonatal Hemodynamic Research Center. I'll start by, before I forget, big thanks to Laura Thomas and to Megan Hudak, who helps us all the time to prepare these sessions. Without their help, we would not be able to run them. So that's we're very appreciative and grateful for this. So for today's session, I want to mention that we're very excited to have Dr. Angelica Vasquez. Dr. Angelica Vasquez is a neonatal cardiac intensivist at Columbia University Medical Center. She completed her pediatric residency and her neonatal perinatal medicine fellowship at Columbia University, and she received training in neonatal hemodynamics at the University of Iowa. She then returned to Columbia University Medical Center to complete an instructor year in neonatal cardiac ICU medicine, and her areas of academic focus include cardiac and cerebral hemodynamics and the use of non-invasive clinical monitoring tools to optimize the care of premature and critically ill neonates. So a few other things. We want to acknowledge the fact that the TNEMP Foundation curriculum is supported by an unrestricted educational grant from Mallinckrodt Pharmaceuticals. And this session is accredited by the Royal College of Physician and Surgeon of Canada for Section 1 CME credits. For the session, what will happen is that Dr. Vasquez will be giving us 30 minutes of didactic information and lecture on the physiology surrounding congenital heart defect. And then following that, we'll have our closed session. Following that, we'll have a Q&A for the audience to provide us for questions. So please use the Q&A button in order to send in your questions, and we'll have a 10-minute period where we'll be able to ask questions to Dr. Vasquez to provide her, to give us her insight and expertise on the topic. And then following this, all the fellows and trainees, panelists will go into another Zoom room where we will have the case discussion in a closed format. So on this note, Dr. Vasquez, thank you so much for accepting to present to our community, and the floor is yours.
Okay, thank you. Let me see if I can share my screen.
Yes,
see my screen?
we see your screen. Absolutely.
Okay, perfect. Okay. So first and foremost, thank you very much for the invitation to speak today. I'm really excited to be talking about a topic that I happen to love, but that I know can sometimes provoke a little bit of confusion and anxiety. So this talk is going to have a little bit more of a clinical and physiology-based focus rather than echo basis. And my hope is that it's going to provide a little bit of structure on how to think about the physiology of these babies, and so that we can use that understanding to subsequently steer management and help stabilize these babies while they're in our NICUs. These are our learning objectives for today. And before we jump into what's abnormal, I think it's very important to establish what normal cardiovascular circulation entails so that we can appropriately tailor what to expect when we're facing different anatomies. And when we're talking about the structurally normal heart, we know that the anatomic structures are arranged in series after birth, where you have deoxygenated blood coming back from your systemic veins and returning to the right heart, then passing out through your pulmonary arteries to your lungs, where they pick up oxygen. And that red oxygenated blood then returns back to the left side of the heart through your pulmonary veins, and then ultimately exits out through your aorta to the rest of your body. And in normal circumstances, assuming that you do not have significant pulmonary insufficiency or aortic insufficiency, then you expect that the stroke volume that's coming out of your right ventricle through your right ventricular outflow tract should equal the stroke volume that's coming out of your left ventricular outflow tract. As a result, that QP is that basically represents that volume of blood that's flowing through your pulmonary circulation, whereas your QS refers to the volume of blood that's going through your systemic circulation. And so we expect that the ratio of your pulmonary to systemic blood flow, or your QP to QS ratio, should be 1-to-1 when you have the absence of any shunts. As a result, assuming that you have normal systemic venous sats and normal pulmonary venous sats returning to the heart, then you expect that your normal oxygen saturation should be greater than or equal to 96%. However, when you have any sort of intra or extracardiac shunts, then you end up with mixing of blood. And so not all of that blood flow participates in gas exchange. And so there are a different set of quote unquote normal sat range parameters that we should be targeting depending on what your lesion that you're dealing with is. When you have left to right sided shunts, that oxygenated blood from the left side is crossing over through some sort of abnormal communication into your right heart. And so you have more blood or effective QP coming out of your right ventricular outflow tract. As a result, when you have your left to right shunts, those are babies that are going to have higher QP to QS ratio. Because you have oxygenated blood coming over into the right heart, and that blood is subsequently going back to your lungs to pick up oxygen, babies who have left to right shunts are not babies that we typically expect to present with desaturations as a result of their cardiac defect. When you have right to left sided shunts, however, you have deoxygenated blood coming from the right side of your heart, crossing over into your left sided systemic circulation. And so as a result, you have desaturated blood going out in through your aorta. And so these are babies that have less effective QP to QS ratio. And so your QP to QS will be less than 1-to-1. And these are babies that you would expect or anticipate to see a little bit of systemic desaturation. In congenital heart disease, it is not uncommon that we have multiple level shunts. And so that QP to QS ratio is actually going to be reflective of the net shunt directionality. And that net shunt directionality is going to be dependent on multiple factors. For example, the size of the defect, as well as the relative pressure gradient across that opening. When we're talking about neonates with congenital heart disease, we are dealing with a very wide spectrum of possible anatomic variation with significant pathophysiologic heterogeneity. As a result, these are babies that can have many different phenotypic variations in terms of the age or timing at presentation, as well as their clinical symptomatology with which they present, with some babies being asymptomatic, while some symptomatic babies will present with symptoms such as tachypnea, compromised perfusion, or cyanosis. When we are thinking about when the baby with congenital heart disease will present, there are 4 general timeframes in which symptomatic cardiac babies present. And those are either from right after birth in the delivery room, within the nursery, or about 1 to 2 weeks of life, and then around that 4 to 6 week period of time. And that timing has to do with important physiologic changes that these babies are experiencing when they transition from life from in utero to ex utero. Without the initiation of prostaglandin or PGE, most infants will experience spontaneous ductal closure within the first few days, few hours to first 1 to 2 weeks of life. And so when you have babies with ductal dependent systemic or pulmonary circulation, that timing of presentation is going to depend on when that duct closes. So those are babies that might present within the nursery or in that 1 to 2 week period of time. On the graph on the right, you can see that right after birth, babies experience a decrease in their pulmonary vascular resistance, which continues to decrease until about a nadir of around 6 weeks of life. That's accompanied by an increase in your pulmonary blood flow. And also in that same time period, babies are experiencing increases in their systemic blood flow in the setting of lower blood viscosity and physiologic anemia, with that same nadir in hemoglobin occurring around 6 weeks. As a result of these physiologic changes, cardiac babies who have communications between their systemic and their pulmonary circuit experience changes in the differences in resistance across these circuits as the pulmonary vascular resistance goes down. And so they have increases in their pulmonary blood flow, and depending on the lesion, that increase in pulmonary blood flow may tip the scale so that they have decreased body blood flow. There's many ways out there to try and categorize congenital heart defects, but I like to break them down by hemodynamic categories, as I feel it provides a little bit more physiologic insight. And there's 5 main categories that I like to think about. The first of which are lesions that cause excessive pulmonary blood flow. And this is where your left to right shunt lesions fall, with excess pulmonary blood flow occurring because of a large volume of fully saturated pulmonary venous blood being diverted back into the pulmonary arteries via some sort of abnormal communication. And like we mentioned earlier, these are not babies that typically present with systemic desaturation. When I think about left to right shunt lesions, I like to subgroup them into your pre-tricuspid shunts. And those are going to include your partial anomalous pulmonary veins, where you have at least one pulmonary vein that drains abnormally to the right side of the heart rather than connecting to the left atrium. And then you have your atrial septal defects. And these are both lesions that will result in right heart volume loading. In both of these lesions, the degree of shunting is driven by differences in their ventricular compliance. It is relatively atypical with some exceptions that these are babies that become symptomatic as a result of their cardiac lesion within the NICU. And then the other subgroup that you have are going to be your post-tricuspid shunts. And so these are shunts that are occurring at the atrioventricular level, the ventricular level, and then your arterial level. And these are lesions that include AV septal defects, VSDs, and then at the arterial level, you have things like PDA, which we've heard many talks on beforehand, as well as AP windows. And in these lesions, the degree of shunting is driven predominantly by differences in the ratio between your systemic and your pulmonary vascular resistance. And when you have connections at the arterial level, these are lesions that oftentimes can result in significant diastolic runoff, which can have other clinical consequences. When we are talking about these left to right sided shunt lesions, these are lesions where the babies will tend to become symptomatic around that 4 to 6 week time period when you have that nadir in your pulmonary vascular resistance. And as a result, you have increased pulmonary blood flow to the point that you develop pulmonary interstitial edema. As a result, you have decreased lung compliance. And so these babies will clinically present with tachypnea and grunting. And as they have more and more volume loading and increased metabolic demand, eventually those babies will go on to develop heart failure symptoms with things like difficulty feeding and failure to thrive. The next subgroup of babies are your babies that present with decreased systemic blood flow. And these are usually left-sided obstructive lesions. And obstruction can really occur at any point along the left-sided pathway, either at the level of inflow into your left ventricle, so at your mitral level with mitral stenosis, or at the level of outflow from the left ventricle, so at the level of the aortic valve, or anywhere along the aorta, such as in coarctation and interruption of the aortic arch. Additionally, obstruction can occur at multiple sites, and this is often something we call Schoen's variant. And so when you have left-sided obstruction, this results in your left ventricle facing increased afterload, which results in increased filling pressures. That can back up into your lungs and cause some pulmonary edema. Additionally, it can also result in pulmonary venous hypertension, and through maldevelopment and remodeling of your pulmonary vascular bed, you can also end up with a reactive component of pulmonary arterial hypertension as well. These babies, as the left ventricle faces this increased afterload, can also develop diastolic and systolic dysfunction as well. And in the case of critical aortic stenosis, critical coarctations, and interrupted aortic arch, these are lesions that we qualify as ductal dependent for systemic circulation. And so these are babies where they require prostaglandin infusion initiation in order to maintain adequate systemic blood flow. When we're assessing the newborn for congenital heart disease, it's very important to understand the significance of differential cyanosis, where if you have a pre and post ductal SAT differential, what it's telling you is that one, you have an open duct, and two, that you have a pressure gradient between your aorta and your pulmonary artery, whether that be due to high pulmonary pressures, such as in pulmonary hypertension, or due to some sort of upstream obstructive lesions, such as coarctation of the aorta and interrupted aortic arches. If you have a pre and post ductal SAT differential, what it's telling you is that you have a situation where you're dealing on the PDA, or you're relying on the PDA having right to left shunting in order to provide adequate distal systemic blood flow. Additionally, your physical exam and your four extremity blood pressure gradients are very important to help you discern when you have one of these ductal dependent systemic circulation lesions, like a coarctation, whether the absence of a pre and post ductal SAT differential is due to having an adequately supported baby who's just getting enough systemic blood flow through some sort of bidirectional PDA, versus a situation where you actually have restriction or closure of that ductus, and that the lack of pre and post ductal SAT differential is that your PDA has gone away. And so this is a baby that's actually going to be at risk of developing shock due to compromised distal systemic perfusion. And so, as I mentioned earlier, these are babies that are going to present either in the nursery with decreased distal pulses, for example, or at 1 to 2 weeks of life if they go unrecognized, and they'll present depending on the timing of their ductal closure. In the most extreme of these cases, you have a lesion known as hypoplastic left heart syndrome. And it's characterized by a severe underdevelopment of your left ventricle with either mitral stenosis or mitral atresia, and aortic stenosis and aortic atresia. As a result of these underdevelopment of your left ventricle, the left side of the heart is basically unable to support your systemic circulation. As a result, these babies function as a single ventricle, where your right ventricle actually works as your main systemic pumping chamber. And these are babies that have an unrestricted atrial communication, so that the well-oxygenated pulmonary blood flow that's returning to the left atrium can mix with the desaturated blood coming back from the systemic circulation, and then go to your left ventricle and ultimately provide blood flow to your lungs through your pulmonary artery and through your body through the ductus arteriosus. These are babies, like I mentioned, that have what we call single ventricle physiology. And when you have single ventricle patients, that optimal systemic delivery, oxygen systemic delivery, is going to occur when you have a good balance between your QP to QS, and that balance is about 1 to 1. Clinically, that correlates with saturations that are between 75 to 85%. However, in these lesions, because you have that blood that's mixing prior to the level of the ductus, they're not going to present with a differential cyanosis in this situation. These are babies that when they are in the preoperative period and also postoperative, but we'll focus on pre-ops. So we have to be paying very close attention to the arterial blood gases and things like your PaO2s. If you have a preoperative hypoplast that has preoperative PaO2s that are going into your 45 and 50 range, there should be concern, because it's a baby that's showing you that they're having a lot more pulmonary blood flow. And so as a result, those are babies that can present with systemic steal, as they have less and less QS or blood flow to their body. And so when we're taking care of these babies, we have to make sure that we're keeping in mind that our goal is to always maintain adequate systemic perfusion by making sure they have adequate mixing at the atrial level, that their ductus or PDA is not restricted, and that their right ventricle or their one main pumping chamber is adequately supported. And most importantly, that we must focus on always maintaining appropriate SATs and trying to keep that balance between your QP and your QS. And in order to do so, you need to avoid using exogenous FiO2 and not letting these babies sat 90 something, because those are situations where you're going to end up with less perfusion to your body. In the next category, we have lesions with cyanosis that's a result of decreased pulmonary blood flow. And these are lesions that can be broken down into 3 main groups. Those are lesions with inflow obstruction, lesions with outflow obstruction, and lesions with valvar regurgitation. Whenever you have obstruction either within the heart or at the level of the pulmonary artery, or severe regurgitation at the level of the tricuspid or the pulmonary valve, those are babies that have less effective pulmonary blood flow, as you have right to left shunting at the atrial level. In some lesions, such as tetralogy of Fallot, you'll also have some right to left shunting at a ventricular level as well. And in cases where you have severe obstruction, these babies may even become ductal dependent for pulmonary blood flow. Because these are babies that have right to left shunting, these are babies that can present with systemic arterial desaturation. However, because these babies have mixing of blood that occurs prior to the level of the PDA, these are not babies that are going to present with a differential cyanosis. And so you expect that their upper and their lower extremity blood pressures should remain the same. When you have inflow, RV inflow obstructive lesions, even if you have a tricuspid valve, sometimes it can be very hypoplastic, and you can have subsequent hypoplasia of your right ventricle. And these are babies that in the extreme can present with something called hypoplastic right heart syndrome, where again, we have a single ventricle physiology and your expected saturations are in that 75 to 85% range. These babies who have decreased pulmonary blood flow as a result of obstruction can have a very wide spectrum of of clinical presentation, whether it's mild with just a murmur, if you just have some mild PS, or it can be at the extreme where they have such significant obstruction or decrease in pulmonary blood flow that they're become ductal dependent for pulmonary blood flow. Similar to when you have obstruction to the left ventricle, whenever you have obstruction in the RV, in the right ventricular outflow tract, your right ventricle is facing increased afterload. As a result, you have increased right-sided heart pressures, and you have the right ventricle that develops hypertrophy and can also have diastolic and systolic dysfunction. Because these babies tend to present with cyanosis and murmur, these are usually lesions that will present either in the delivery room or in the nursery. In the other subgroup of babies, we have babies that have decreased pulmonary blood flow as a result of valvar regurgitation. And these are lesions that can have variable presentations depending on the severity. The first subgroup we have in this bucket is your Epstein's anomaly, where you have variable degrees of inferior displacement of your tricuspid valve with the septal and the posterior mural leaflets of the tricuspid valve sometimes being abnormal to the point that you have severe tricuspid regurgitation resulting in right atrial dilation and cardiomegaly. And this, as a result of this regurgitant flow, you have less flow coming out of your right ventricular outflow tract. And so they rely on right to left shunting across the atrial communication. And so that's going to make them present with cyanosis. Epstein's can have different flavors. In some babies, you have a fixed anatomic obstruction at the right ventricular outflow tract or pulmonary atresia. And so those are babies that are ductal dependent for pulmonary blood flow because the blood cannot flow antegrade out of your right ventricular outflow tract. There is also a subtype of these babies who have actually pulmonary insufficiency as a result of their right ventricle being inadequately able to pump blood out of their out the right ventricular outflow tract into their pulmonary arteries. And so these are babies that can present with severe cyanosis and shock as a result of the circular shunt, where you have pulmonary insufficiency and tricuspid insufficiency, right to left shunting at the atrial level. Then your blood pumps out of the left ventricle through the aorta. But if you are having, those babies might end up having the PDA, it goes through the PDA and instead just has a circular shunt this way. So you're not going to have effective cardiac output. And basically the blood is just swishing around within the heart and avoiding the systemic capillary systems. The other subgroup you have is your tetralogy of Fallot with an absent pulmonary valve. In these babies, you have to and from flow across that absent valve. And so you have dilation of your MPA, and that causes compression of your main stem bronchi. These babies, again, can have variable presentation depending on the degree of dilation of the MPA. And so they'll present with cyanosis, but they can also have respiratory failure due to bronchial compression. So these are two lesions to think about if you're in the delivery room and you have cyanosis and respiratory distress from the get-go in the delivery room. The next subgroup are lesions with cyanosis caused by parallel circulation. And this is one main group of lesions called your transposition of your great arteries. In this lesion, you have your aorta and your pulmonary artery coming off opposite ventricles than they should be, so that the blue blood coming out of your right ventricle is actually going to your aorta, and that your left ventricle output is actually going to your pulmonary arteries. As a result, in these babies, that desaturated blood coming out of the right ventricle goes to the aorta, back to the body, and then back to the right heart, while the oxygenated blood that is going out of your left ventricle goes to the pulmonary arteries, the lungs, and back to your left heart. This is basically a lesion where you have parallel circulations with complete separations of the two circuits. And this lesion is actually incompatible in life unless you have adequate levels of communication between the two circuits. And that can occur at multiple locations, such as the atrial level, which is the best place for mixing, ventricle level, and the ductal level as well. Clinical presentation of these babies is very much dependent on what the degree of mixing available is. If you have a TGA with an intact ventricular septum and a restrictive atrial communication, those are babies that are going to present with profound desaturation in the delivery room with saturations in the 30s and 40s, and they will become profoundly acidotic and you require an emergent balloon atrial septostomy. Meanwhile, if you have a baby who has a large VSD and a good atrial communication, they don't present with they have good mixing, and so they won't present with profound cyanosis. And in some cases, they could even go undiagnosed and present in heart failure symptoms later on as their pulmonary vascular resistance drops and they have increased volume loading. When we are talking about TGA, we have to talk about the sort of pathognomonic clinical feature of transposition physiology, which is a reverse differential. When you have a reverse differential, you're referring to a situation where your preductal sats or your arm sats are actually lower than your lower extremity sats. So it's the opposite of your differential cyanosis that we talked about earlier. And this is going to occur because you're having in two situations. Either you have that upstream obstruction such as coarctation and TGA, or you have pulmonary hypertension or an elevated pulmonary vascular resistance. And so you're having blood that's shunting from your pulmonary artery to your aorta due to either high pressure in your lungs or because of some ductal dependent systemic blood flow lesion that is also accompanying the TGA baby. And so these are the two main situations that you have to think about. Sometimes you'll see it in the very beginning when the babies are first transitioning, and as the pulmonary vascular resistance goes away, then they will no longer have that pre and post ductal sat differential. So it's not something that the absence of the reverse differential means you don't have a TGA, but you should always be suspicious if you see one. And then the last subgroup of babies that we have are going to be the babies that have large left to right shunts, but who also have a degree of right to left shunting. And these are lesions that can have a little bit of overlap in terms of their clinical presentation. As a result of the right to left component of the shunting, they can have some systemic arterial desaturation, but in these babies, overall, the net shunt is going to be left to right. And so the clinical effects of desaturation are actually relatively negligible in these babies. And the clinical picture is driven predominantly by that pulmonary overcirculation phenotype that's going to be how they present. There's two main lesions that fall into this category, and those are going to be your truncus arteriosus babies and your unobstructed TAPVR babies. When you have a truncus arteriosus, you have a single arterial blood vessel that basically gives rise to the systemic, pulmonary, and the coronary circulations. And these are babies that always have an accompanying VSD as part of the defect. In these lesions, all of the pulmonary and systemic blood flow are mixing in this combined outflow tract. And so when your pulmonary vascular resistance is high, such as in the very beginning when you're first born, then they might present with some cyanosis as you have that right to left shunting. However, as pulmonary vascular resistance drops, then they develop more of that left to right heart shunting, resulting in excessive pulmonary blood flow, and frequently they develop heart failure symptoms. And so the clinical presentation is going to be dependent on how fast your PVR drops. And so the cyanosis is really something that we mostly see in the very beginning. In the other subgroup of babies that fall into this category are going to be your unobstructed TAPVRs. And you have sort of three main flavors, well, four if you count the mixed types, but you can have supracardiac, intracardiac, or infracardiac TAPVR. In all of these lesions, instead of having your pulmonary veins drain to your left atrium, they have anomalous pulmonary venous return connections, so that all of these babies will have an obligate left to right shunt from the pulmonary venous return to the right heart, whether it be the IVC, the coronary sinus, or some sort of vertical vein that connects to your SVC. And then these babies, as a result, also have an obligate right to left intracardiac shunt so that the blood that's returning to the right heart can cross through that atrial communication to the left atrium, and then you can have subsequent cardiac output through your aorta. In the absence of obstruction, these babies can either be asymptomatic or present with some transient cyanosis and perhaps some mild systemic desaturation. And if they go undiagnosed, then they can develop pulmonary overcirculation as that PVR drops and they have more and more left to right shunting. When you have supradiaphragmatic TAPVR, this is a situation where it's the other situation where you could potentially have a reverse differential. It's less common. And in this situation, it's due to having a little right to left shunt, but it's predominantly due to the straining that occurs as the SVC and the IVC drains in these babies. So that's just the other clinical pearl to have in the back of your minds with these babies. Whenever we talk about TAPVR, we have to talk about what happens if you have obstructed TAPVR. And so regardless of which flavor of TAPVR you have, all of these babies, when you have obstructed TAPVR, you can have a very dramatic presentation. And these are babies that can present with cyanosis, tachypnea, and increased work of breathing with pulmonary edema and whiteout on X-ray as that pulmonary venous return gets obstructed and you have worsening backup of edema into your lungs because you're not able to drain. And then these babies, as a result of the obstruction, have less blood returning to the left heart, so they can have low cardiac output and hypotension and a low cardiac output state. And because of worsening pulmonary venous hypertension, can have worsening pulmonary hypertension, and the right ventricle can get bulged and cause bad ventricular-ventricular interactions and exacerbate that shock-like low cardiac output state. This is a surgical emergency, and it's very important to always have it in your differential when we're taking care of these babies, because the clinical presentation can really mimic severe pulmonary hypertension, with the exception that in this situation, the use of a pulmonary vasodilator like nitric oxide can actually have very deleterious effect and worsen the obstruction. And so I hope that this talk helped provide a little bit of insight into the underlying physiologies at play in the major subtypes of congenital heart diseases, as well as when these babies might be encountered within our clinical practice in the NICU. And of course, the importance of always keeping in mind that congenital heart disease may be the problem, and sometimes it is the heart. And of course, the importance of targeting appropriate saturation goals and expectations based on that individual baby's needs in order to mitigate detrimental changes in their systemic and pulmonary vascular resistance. And sort of keep in mind that our goal is to always keep stable circulation in these babies until they can undergo subsequent palliative cath and surgical interventions. And so these are my references, and I'd be happy to take any questions.
Dr. Vasquez, thank you so much. That was an outstanding review of the CHD in 35 minutes. I don't know how you even made it. It's just like incredible amount of content and so clearly delivered. So thank you so much. Really nice review of the physiology. We're now open for the Q&A session. So we already have a first question, which is related to the pre-interventional nutritional support of these patients, and whether in your practice or your center how do you approach, I guess, the nutritional enteral support of these patients, knowing that they may be at risk of intestinal underperfusion depending on certain physiologies? And so do you have particular protocol? Do you start them on trophic feeds? And are there specific categories that you advance or not? And do you use like other key monitoring tools like Dopplers of the aorta or NIRS to guide risk of underperfusion of the intestine?
Okay, so big question. So these are babies where nutrition is of utmost importance. So our general practice, I will first go with in terms of clinical monitoring tools. We're a huge unit in terms of using renal NIRS, even in the preoperative period, in terms of being able to assess the baby's overall evidence of systemic perfusion and their whether this is a baby that's having evidence of increased fractional oxygen extraction. And so we take every baby sort of one baby at a time. And there are different ways that we approach different lesions. So we are big on starting trophic feeds. We are a unit where we'll encourage EBM, and as long as the family is amenable, if there is no EBM available, then we'll use donor milk. But we're pretty quick about starting trophic feeds from the get-go. Even in our single ventricle and our left-sided obstructive lesion babies, first things first, you always make sure that the babies are showing signs of adequate systemic perfusion. If that's not the case, that's probably not a baby that we're going to feed. But for the most part, these babies are safe to feed, at least to some degree enterally, even in the preoperative period. And we have wonderful nutritionists that we're very reliant on in terms of helping us start these babies on TPN, and we'll start trophic feeds early for them. In terms of the pre-op left-sided obstructive lesions in single ventricle babies, we won't necessarily start like advancing NG tube feeds very heavily, but if that baby is willing and able to eat on their own, then we're more liberal about letting them eat as much as they want. Usually we might cap it at like 20 cc's depending on the baby, but just so that they can work a little bit on those oral skills, because we obviously know that these are babies that are at higher risk of developing oral aversion and things like that with all the procedures they undergo.
Thank you. That was a nice comprehensive input on this topic that could take another 3 hours to discuss, I'm sure.
It's a whole talk in and of itself.
I know. We had another question from the audience about specifically patients with, I suppose, detransposition of great arteries, and who, my understanding from the question is a patient coming out in the delivery room with borderline systemic saturations in the 60s, that has no oxygen or respiratory distress. What would be your approach in terms of, I guess, preparation to septostomy in your setting?
So we have a very good relationship, obviously, with our cardiology colleagues here. Whenever we have an anticipated delivery of a baby with transposition of the great arteries, we always have our CAS team aware. I think a really important thing to always keep in mind is when you're dealing with a TGA that you should always sort of prepare for the worst case scenario, which is that you're going to have a baby with profound cyanosis that's not going to have adequate mixing. Yes, you feel a little bit reassured about them having VSD sometimes, but there are many times that it's not quite enough. And so in terms of our preparation for those babies is that if the baby is going to be delivered, we let the CAS team know so that they're on standby as well. Our cardiology colleagues are, and the fellow and the attending are very much aware, and that one of our NICU colleagues will also go. So those are babies that we will all go to we have something called the transitional nursery, which is where we stabilize these babies. And so if you have a baby who's not meeting the oxygen saturation goals you're hoping for at least ideally in the 80s, but like even if they're at least 75 and up. But if you have a baby that's showing the signs of inadequate mixing, those are babies that would be, even if they weren't if you have a baby who is satting 60s or so, those are babies that are showing you that you have parallel circulation. Those are babies that will over time become acidotic, and they will start to develop respiratory symptoms, even if they didn't maybe from the initial get-go. So those are babies that we would be very prompt to intubate, obviously put on oxygen if you had, and then we would have the CAS team perform the balloon atrial septostomy within the transitional nursery once we administered sedation. So a lot of times they're able to do it through the UVC, but if not, we have ultrasound guidance, ultrasounds available for them to provide it through the femorals.
Amazing. That's pretty much copy paste of what we do locally. And I love your key message of saying, never get reassured by an antenatal fetal echo telling you there's a VSD. You cannot rely on that. Hopefully that could be a key message that goes to whoever is listening right now. Do not rely on VSD. You will get burned.
Yes,
these patients
you will.
have, balanced, they have high PVR. So that VSD is often insufficient for mixing. I don't see any other question in the chat, but maybe I'll close off this particular session with one last question, which I don't know if it's a topic of controversy or not, but I know some centers that in TGA will initiate PGE, will get their septostomy, and once they establish appropriate mixing is there at the atrial level, they'll stop their prostaglandin. And I know other centers that are a bit more careful and they want to actually increase the amount of pulmonary blood flow to maximize LE preload and favor the shunt at the atrial level. So, and obviously there's PGAs with posterior shelves and likely coarcts or small arch. And then there's always the concern we miss that. So I'm wondering, in your approach at Columbia, do you guys do the septostomy, stop PGE and monitor, or do you have a tendency to keep the PG on until repair?
So I think general practices, those are babies that will from the beginning get at least a PIV umbilical lines and start PGE. If they require a balloon atrial septostomy, they will stay on their, we're very quick about extubating babies here. And so we would work to extubate the baby. And then once, assuming the saturations were adequate, it honestly depends on what your saturations are. So if you have a baby that from the get-go was having reverse differential, and even after the balloon still has a reverse differential, that's a baby where you know the PVR is higher. And so there's usually less inclination to try and wean those babies off of PG. Obviously, this is assuming you've cleared the arch. Just because you already know that baby didn't have that much pulmonary blood flow. So even though you might have an adequate atrial communication, you're probably going to benefit from that additional preload to the LA from the PDA. And so those are babies that I don't usually try weaning off. And we're pretty good about getting our babies to the OR within less than 4 days of life. So a lot of times there's not too much time for trialing off the PGE. If there's a baby that for whatever reason is going to have a more prolonged period and you have SATs in the 90s, you're typically you're starting Lasix, CPAP, those might be babies that you trial off. But again, I almost never has it worked in my favor if I've tried PGE off of PGE if they had a reverse differential. So for those babies, I don't even try. And for they honestly go to the OR so fast that usually we just leave it on, but it kind of depends. And if it's a baby that's having has a little more time prior to the OR and higher sets, those might be the situations where I try it.
Dr. Vasquez, thank you so much. Everything was really spectacular. We had clear clarity on the amazing physiology you outlined. I believe Laura will be posting now in the chat the next Zoom link for the case discussion. As she's doing that, I'm just going to mention to all our panelists and fellows to please open that link and close the current session in order to pass on to the clinical case discussion. So thank you again. This was great for the audience and community of the NHRC. So on this note, we'll move to the next link and we'll see everyone at the next block in May for our next speakers. So let's open the chat and then see you on the other Zoom. Thank you again.